I'm Dr. Latifa Berrezouga. So I'm professor in medical microbiology and immunology, and I'm also practicing endodontics, dental traumatology, and I investigate also the link between dentistry and medicine. So I'm a member of the Excellence of Endodontics group. I'm also a member of the International Association for Dental Oral and Craniofacial Research. I'm also a member of the International Association of Dental Traumatology. I would like really to thank Dr. Maison Domini for his kind invitation to bring, in fact, scientific information about an unusual lesion of endodontic origin. So if you plan to come to Tunisia, so welcome to my beloved country. Otherwise, I will speak about this unusual lesion occurring in a patient, and I got really the chance to see her after a couple of years, 70 years. So when you see that type of lesion appendant to the apex, we know that the pulp inside is necrosed, and in that case, of course, and that this necrosis is due to a biofilm predominated by bacteria. And these bacteria will enhance the periapical system or the pre-radicular system and will induce inflammation. And this inflammation will substitute, okay, the tissues here, the periodontal ligament, the bone, and this lesion will develop because there's a resorption of tissues here. But no one can really confirm at 100% that this lesion is a granuloma or a cystic lesion or an FCS. No, it's not really, it's not an FCS, but here, we may find inside the lesion pass, for example. But nor clinic or radiography can really diagnose at 100% systematically the type of the lesion. And the gold standard for the diagnosis of the lesion is histopathology. What you see here is the apex here, okay? It's a portion of the apex. And here, this is a periapical lesion, a portion of the periapical lesion. This lesion has been enucleated by surgery. And what we see here are really an inflammatory tissue, okay? And this inflammatory tissue is made up of different types of cells, what we call infiltrate, inflammatory infiltrate, made up of different types of cells. You will see some types of cells included in these lesions. So when we speak about cystic lesions, generally, two types of cystic lesions have been described. The true cyst that is not in direct contact with the endodontic system, infected endodontic system, and the pocket cyst, which is in direct contact with the endodontic system. And we assume that generally, when we properly disinfect the root canal system and reobturate, there's a risk that true cysts do not heal. And we have to remove the lesion by microsurgery. But if the lesion for a pocket cyst is in direct contact with the canal system and we disinfect properly and we obturate properly, fill properly the canal, there will be healing of this lesion, okay? So this lesion is induced by what we call a biofilm. This periapical lesion is induced by a biofilm, and a biofilm is so complex. Even if we know that bacteria are the predominant species in this biofilm, okay? But we may find also fungi. We may describe also viruses, herpes viruses that have been found in periapical lesions. But generally, we find bacteria. Bacteria are organized as a biofilm that can invade the whole endodontic system, irregularities of the endodontic system, the isthmus, for example, lateral canals, the apical delta, the foramina. And this biofilm has also the ability to extrude from the apex or apices and to invade the periapical or the periradicular area. So this is an extraradicular biofilm. This is an intraradicular biofilm, okay? This is the periapical lesion. These are histopatological slides, okay? This is the periapical lesion, and this is the extraradicular biofilm. And this extraradicular biofilm here, for example, is an actinomycotic biofilm. These are bacteria, you know, bacteria of actinomyces. So my patient is at that time in 2005, a young patient of 32 years old. At that time, she consulted the department in emergency for a swelling, endobuccal swelling, a very painful swelling. And she reported a history of dental trauma occurred at the level of the mandibular incisors. We see here, for example, fracture, here, for example, a fracture of the enamel and the dentin, but not really a fracture. This is a non-complicated fracture. So also the patient reported hyposensitivity, even if I did the vitality testing, which was negative on the mandibular incisors. When I took the retroviral radiograph, look at this displacement of the roots of inferior and mandibular incisors, and the lesion was so big. So at that time in Tunisia, in 2005, we had no CBCT. So I took a panoramic radiograph, and we discovered this huge lesion, very important lesion, with the thickening of the cortical bone here, displacement of the roots here, that may propose the diagnosis of cystic lesion. Indeed, when you have that type of yellowish blood, I can say that I'm nearly sure that it could be a cystic lesion. So this yellowish blood coming from the cavity excess, mainly from this tooth, this fractured tooth, will pass. And these crystals, you know, it could indicate crystals, you know, some types of crystals, cholesterol crystals that may maintain the lesions and contribute to maintain the persistent periapical lesion. So this clinical also finding may probably indicate the presence of a cystic lesion, but we are not really, we have to be sure by the histopathology. But there are, we have indices, you know. So for an additional decompression of the lesion, which is big and plenty of floods and pus, I did a decompression, you know, with an incision. So I got my drainage here from the canal and also the drainage from the this incision to allow the decompression of the lesion. This is a very big lesion. So after preparation, of course, disinfection of the inside of the canals of these mandibular incisors, mechanical preparation. I did, of course, an additional disinfection of the root canals by calcium hydroxide, okay? And then I see my patient after 2 years and look at the healing of this lesion after 2 years. I would like just to remind you that after endodontic treatment, the lesion was, of course, enucleated by microsurgery, of course, because even with endodontic treatment, we have persistence of symptoms, of course, and pain. So the lesion was enucleated and removed by microsurgery, and the surgery was performed by my colleague, Professor Hamdi, at the dental clinic of Monastir. Hamdi Habib, of course. So when you see here, after the microsurgery, this is after 2 years. So you see here the repositioning of the tooth by the regeneration of all tissues, okay? Bone tissues, the alveolar ligament, and you see here this kind of healing of this very big lesion, okay? So when you did histology, this is very interesting because the histology confirmed the cystic lesion. You have this cavity of the cystic lesion lined by the epithelium, as you see here. This epithelium may derive from the rest of Malassez, you know, but also we have several origins of the epithelium in periapical lesions. In the maxilla, we may have from the epithelium from the maxillary sinus, or we may have proliferation of the epithelium due to inflammation, you know, which is induced by bacteria. We may have proliferation of epithelium from sinus tracts, for example. Which is very interesting here that you have this epithelium lining this cavity, and we have the connective tissue here with the inflammatory infiltrate. Okay, this is with magnification. You see this inflammatory infiltrate made up of cells. So we have several types of cells, you know, for example, neutrophils, lymphocytes, mast cells, giant cells that are macrophages, you know. This is an example of giant cells, multinucleated giant cells that are macrophages. You know, macrophages are cells of the immune system that are cells that phagocyte, you know, the foreign bodies and aggressor like bacteria or several types of microorganisms and foreign bodies, for example. But these cells cannot digest or phagocyte cholesterol, you know, crystals. So what you see here, not really crystals, but lefts of cholesterol. And these lefts of cholesterol are also implicated in the maintaining also of the periapical lesion. So this inflammatory infiltrate, and this is the epithelium, okay, with the magnification, stratified epithelium. And this is really characteristic of cystic lesions, even if in the granuloma lesions, we may find epithelium, you know, because the epithelium also is the the consequence of the result of the inflammation. So we have proliferation of the epithelium. But in the granuloma, we have no cavity, no liquids. This flood that you have seen here, you know, this yellowish flood and these parts with crystals here. In the granuloma, we have a solid tissue, okay, with no cavity with a flood, okay? So just to also to show you really the diagnosis of a cystic lesion. But you have also fungi. We may find, for example, Candida albicans in the periapical lesion. We may find also molecules like immunoglobulins, for example, and also other molecules such as cytokines, you know, that cytokines and pro-inflammatory cytokines, for example, IL-6, for example, or IL-1, that are pro-inflammatory cytokines involved in the inflammation. So the reaction of the immune system in inducing periapical lesion is very complex, you know. But this reaction of the immune system is due to this aggression, you know, the trauma first, and the trauma lead to the rupture of the vasculature, and the pulp become necrosed, and then bacteria will colonize this necrosed pulp, okay? And this colonization will lead to the infection of the cystic lesion, okay? So this is the patient after 70 years in 2022. And that time, of course, I proposed to the patient to take CBCT, beam computed tomography. And you see after 70 years, the healing of the lesion here, the root canal fillings of these mandibular incisors, and different, here, for example, in the coronal view, this is the occlusal view. Look at this healing of the lesion. And sagittal views. So you have the 231 incisor that was filled at that time, the 4 mandibular incisors, and look at the type of the bone here and the healing. Okay, so this is really very interesting situation, because this trauma leads to the necrosis of a couple of teeth, mandibular teeth, and this necrosis lead to the development of a cystic lesion, which was asymptomatic. Asymptomatic because the necrosis is rather due to the rupture of the vasculature of the blood supply. And once this teeth was necrosed, and this necrosis was at the origin of the cystic lesion, in a second time, these teeth was colonized and invaded by bacteria, because the lesion developed for so many years, you know, and once the cystic lesion become really infected, and the patient were consulted in emergency with this infected cystic lesion. So it was important for this big lesion, even if there are other treatments, you know, there are decompression, marsupialization, there are maybe at that time, probably we cannot at that time choose if we will have only root canal treatment and see if the patient and make marsupialization and with no surgical treatment. But I think that after the root canal treatment, even with disinfection and root canal treatment, the pain is still here, and there's a risk for the for the occurrence of the lesion and the abscess. So the surgery was the only indication. Okay, so this is very interesting, but also we have to consider my it looks like a minor trauma. It could be a trauma, even if we have no important fracture, a complicated fracture. But we know, according to in recent studies and to what I'm doing also in dental traumatology, that even a fracture at the enamel level or the enamel and dental level, which is not complicated, even a concussion, even a subluxation, will lead to the necrosis of the pulp because of the rupture of the blood supply. So we have to consider any type of trauma and prevent this trauma or treat this trauma or follow patients for the pulp necrosis, and maybe the lesion will develop asymptomatically. That's why we have to make clinical checkup and radiography. We control traumatic dental injuries or dental traumatic tooth by radiography to see and to check if there is no periapical lesion evolving asymptomatically. This is very, very important. And I think that the patient is a very interesting situation because we have no fracture, we have no complicated fracture with pulp exposure, but we have a trauma that led at that time to the rupture of the blood supply. So if you want to know more about apical periodontitis or periapical lesion, either the diagnosis or treatment, there are different types of interesting papers here, for example, clinically oriented CBCT, periapical lesions evaluation via 3D CNN algorithm. This is very recent, or an insight into histopathologic examination as a gold standard for the diagnosis of chronic apical periodontitis. Or here also very interesting endodontic periapical lesion, an overview on the etiology, diagnosis, and current treatment modalities. This is really a very interesting paper. Or here, for example, the utility of ultrasonography for diagnosing and differentiating periapical granuloma for necrosis. So if you have any question, you may contact me via the dentistry online. You have my contacts here. Otherwise, I think that I have finished. And of course, just to show you some of my patients and drawings in dentistry. And once again, thank you very much, Dr. Maison Domeni. And I think that I gave and I add more scientific and interesting scientific information. I would like really to thank you all